Hello and welcome to our Recorded Outbreak series, Module 2. This module is for the staff of long-term care homes and retirement homes. We recommend you listen to Module 1 first, as it discusses the outbreak processes and IPAC measures we implement for all outbreaks. This module will go into outbreak control measures specific to respiratory and enteric outbreaks and differentiate between them. Make sure to take your time completing this module and feel free to pause when needed. This is a pre-recorded session. So here's a view of each of the modules that are available within this Outbreak series. It is a progressive series, however we made it into modules because based on your knowledge and previous experience, may only need specific modules or areas. Again, Module 1 and 2 are specific to long-term care homes and retirement homes, while the third one is meant for our congregate living settings that don't fit that definition, such as group homes, treatment facilities, shelters, etc. Because this is pre-recorded, feel free to start and stop at any time. You can also locate all these modules on our website, or you can use the QR code here and it'll bring you to them. Okay, so our outline is we're going to review a little bit of outbreak guidance, and then we're going to move into enteric outbreaks, followed by respiratory outbreaks, and finish with immunizations. By the end of this module, we hope that you'll be able to recognize general outbreak control measures, be familiar with specific outbreak measures between respiratory and enteric outbreaks, and identify areas of improvement within your facility for outbreak control. IPAC likes to use a lot of acronyms, so we do have a point here that allows you to review or come back to them at any point if you're not sure. Okay, let's do a little recap. Recall in the first module, we discussed IPAC control measures that can be implemented to any outbreak, regardless if it's enteric or respiratory. These include implementing additional precautions on anyone showing new infectious symptoms. So you don't need to wait for an outbreak to be declared or a line list to be started in order to put someone on precautions. You can initiate these precautions to err on the side of caution, and if required, you can remove them as needed. Signage is used to indicate any additional precautions for that client, and signage is also used for the building to swiftly communicate what is occurring on site. Continuing on with communication, it also allows it to be clear and concise to get that information out to all your staff, clients, families, and visitors. Hand hygiene, as always, is the key to reducing transmission. Setting the facility up to promote and encourage hand hygiene through adequate supplies, signage, education, and auditing will increase your compliance. For those missed hand hygiene moments and clients who are unable to remain within their room when they're symptomatic, we do initiate enhanced environmental cleaning and additional staff to adhere to this. And as always, ongoing infection prevention and control education to explain the why to everyone ensures compliance. So before, we used to have two separate documents, one for respiratory outbreaks and one for enteric outbreaks. And it would be dependent on the type of facility you worked in, like long-term care and retirement homes. Now you're going to find everything in one guidance document. So congregate living settings that are not long-term care and not retirement homes, and then congregate settings that are. And you're going to do every type of respiratory illness, so influenza, COVID, and enteric outbreaks. They're all in one document rather than having 4 or 5 different ones. It's nice and neat in one area. The big change that the most recent one is the wording is more generic. So this puts the expertise back onto the outbreak management team and your facilities. So a big part of this is due to the mandatory designation of IPAC leads within your long-term care homes and the public health support and the IPAC hub support available to those retirement homes and other congregate living settings. So the ministry expects a certain base level of IPAC knowledge by all their facilities and their staff to understand this guidance and make your own decisions based on your expertise. So this document has been updated a few times, and most recently has been February 2025. Check back often and look for emails because within a couple months it could always be updated again. We see that when a new document is released, they may update it a few times.
Stopping the spread is initiating the additional precautions. Next is to stop ongoing spread. Ideally, those who are ill or suspected to be ill are in a private room, placed in a private room, or roommates are removed from their room. If this is not possible, symptomatic clients are recommended to receive treatments such as physiotherapy or occupational therapy in their rooms, rather than having these treatments in common areas. It is important to keep in mind additional considerations or accommodations for clients with dementia or cognitive impairment who are in isolation. It's important to support these clients in leaving their rooms in ways that minimize the spread of infection. For example, having one to one support with the client at all times when they're outside of their room, ensuring the client wears appropriate PPE and uses alcohol based hand rub, ensuring the client is able to physical distance, and ensuring the client avoids touching surfaces. Unit or facility control measures include restricting movement between affected and non affected areas or units. Hosting facility tours during an outbreak depends on the type and severity of the outbreak, the facility, and whether or not IPAC measures such as masking and physical distancing can be implemented. It is important to consult with the local public health unit for support and advice. Communal dining can continue for well clients only. Consider cohorting clients and implementing additional measures to stop the spread. Tray service is recommended for those on additional precautions. Consult the outbreak management team for recommendations on whether routine group activities may continue for asymptomatic clients to support physical and mental well being, and which mitigation measures should be in place to prevent the spread of infection. Reschedule communal meetings on the affected units or floors. However, other meetings or activities may proceed on non affected units or floors. Discontinue group outings from the affected unit or floor. The outbreak management team should discuss restricting meetings or activities in the entire facility if the outbreak transmits to two or more units or floors. Hosting outside groups such as entertainers, volunteer organizations, and community groups on non outbreak units or floors should be discussed with the outbreak management team. If possible, conduct on site programs such as physiotherapy, recreational therapy, and foot care for clients in their rooms. Precautions should be taken for ill clients. Ensure there is no interaction between staff and the clients of the affected unit or floor, and the participants in on site childcare or other daycare programs. Activities that are of lesser risk for outbreak spread on the unit should be considered over higher risk. For example, bingo is lower risk than group singing during a respiratory outbreak. Chair exercise is lower risk than baking or cooking during an enteric outbreak. High risk activities that should be suspended for the affected units include large group activities and shared transportation. Low risk activities may resume for well clients or for exposed clients if cohorted. IPAC measures should be implemented based on the activity and the outbreak. Group activities can be conducted such that the outbreak unit is cohorted separately from unexposed clients. At the discretion of the public health unit and outbreak management team, group activities for cohorts may resume. Wherever possible, continuing group activities for exposed cohorts is recommended with IPAC measures to support the mental health and well-being of clients. Enhanced visitor monitoring should be in place when in outbreak. This includes educating visitors on proper hand hygiene, signage, and PPE use, and only visiting within the client's room and avoiding communal areas. Caregivers should not be restricted unless they are ill. Exemptions may be given with end of life or palliative patients. Essential caregivers are not recommended to be restricted, but a limit may be required and will be assessed on a case by case basis by the outbreak management team and the facility. Staff should always monitor themselves for symptoms. However, this should be heightened during a suspect or confirmed outbreak. They are to not show up to work if they are ill, and they are to take hand hygiene and PPE precautions if they become ill on site, and they should leave as soon as possible. Staff have a duty to report any illness to their employer and should follow their occupational health directions. During outbreaks, the facility should consider the placement of their staff. If possible, consider minimizing movement between units or floors, especially if some units or floors are not affected. Within the outbreak area, assign staff to either well or ill clients only. Depending on your facility, this may or may not be possible. Another option is to direct movement of care. Well clients are treated by staff prior to that person going to the ill clients. For example, physical therapy should work with well clients in the morning and ill clients in the afternoon to decrease the risk of the spread. During an outbreak, notify environmental cleaning services about the increased need for supplies and services and/or the change in cleaning product or disinfectant if required. Cleaning and disinfecting common areas at least once daily for low-touch surfaces such as shelving, windowsills, whiteboards, or message boards is required. A minimum of twice daily for high-touch surfaces, so doorknobs, door handles, light switches, handrails, phones, elevator buttons, treatment areas, dining areas, and lounge areas. Clean and disinfect immediately for any visibly dirty surfaces. More frequent cleaning may be required for surfaces and items in close proximity to vulnerable client populations. Areas that are not considered common areas, such as private offices and administrative areas, do not require enhanced cleaning and disinfection.
And now we move on to enteric outbreaks. Enteric outbreaks represent a significant burden of illness in congregate settings, and approximately 1,000 to 1,200 gastroenteritis outbreaks are reported annually to public health. The number of cases associated with a single outbreak generally are large and may range from 10 up to 200 people. The three main types of infectious agents causing enteric illness are viruses, such as norovirus, bacteria, such as Salmonella, or parasites, such as Giardia. They all attack people in different ways. Viral gastroenteritis is the leading cause of enteric outbreak in most facilities. This is because of the higher transmission from person to person, especially during the winter months when community incidence is also high. In congregate facilities, norovirus is the most common infectious agent identified and affects both residents and staff. The routes of transmission of noro and other viral bugs are through droplets. So, emesis or vomiting, direct or indirect transmission on contaminated surfaces through improper hand hygiene, and eating or drinking contaminated food or beverages. Norovirus outbreaks include a sudden onset of symptoms of nausea, vomiting, and diarrhea are common and can lead to a high rate of secondary transmission. Because of the symptoms, it allows for more spread. And acute or explosive vomiting and diarrhea spreads higher viral loads onto surfaces around the facility. A propagated epidemic curve, as shown on the slide, demonstrates how person-to-person or secondary transmission can be extremely high with norovirus, as you can see from the multiple spikes in the chart. Although there may be a common source, such as a food item that is responsible for an outbreak, secondary transmission from person to person can and does readily occur. Infected individuals typically shed millions of viral particles, but only a few are needed to cause infection. This is called a low infectious dose and adds to the spread. As you can see on the graph, it will create spikes in cases beyond the initial exposure. Bacteria and parasites are less often the cause of outbreaks, but they can still occur. Some bacterial pathogens, such as Shigella, virotoxin-producing E. coli, and Salmonella typhi, require special considerations. Bacteria and parasites are usually contracted from contaminated sources, such as unwashed produce or unprocessed water, rather than from other people. Their initial attack rate may be higher, but the transmission between person to person is less common, leading to greater success in controlling the outbreak.
A confirmed enteric outbreak definition. That's when you have at least two clients with symptoms meeting your case definition within 48 hours of each other, and there's an epidemiological link that exists. So this may mean the clients are on the same unit, or perhaps they're table mates, or they're on the same floor, or they share a same caregiver, for examples. The case definition in an outbreak is dependent on the presenting signs and symptoms and circumstances. It may vary between outbreaks and also vary during an outbreak. If you do suspect a client, the health unit would like you to report it to us because we'd rather be cautious and have our resources and staff available rather than scrambling last minute. So, a suspected enteric outbreak, at least one of the following must be met: two or more episodes of diarrhea within a 24-hour period, or two or more episodes of vomiting within a 24-hour period, or one episode of diarrhea and one or more episodes of vomiting within a 24-hour period. A little easier way to put it is one of the following must be met within a 24-hour period: two diarrhea, two vomiting, or a minimal one of each. So if you look below here, we have resident A on floor 2. They have one episode of vomiting on December 1st and one episode of diarrhea on December 2nd. So they would be a 1D plus a 1V within a 24-hour period. So you would suspect them. Resident B on floor 2, they had two episodes of diarrhea, both within the same day. So that would be within a 24-hour period. So they would also be suspected of having an enteric. And then resident 3, they only had one episode of diarrhea. So that's someone you'd want to watch, but not necessarily a suspect of an enteric. It could be a one-off as well. So when we look at an enteric case definition, this can vary with the outbreak under investigation. So the outbreak case definitions are established to reflect the disease and circumstances of the outbreak under investigation. The outbreak case definitions should be developed for each individual outbreak based on its characteristics, reviewed during the course of the outbreak, and modified if necessary. And that will ensure that the majority of cases are captured by the definition. The case definitions should be created in consideration of the outbreak definitions. So that will be the enteric case definition would be designed from the outbreak management team. So the facility and the public health unit working together on that. So anytime we're talking about symptoms, it is important to rule out non-infectious causes of those symptoms that could have attributed to them happening. So you'd want to rule out any side effects from any medications the client is on, perhaps any diet changes or food they may have ingested. So example, if they were having prune juice or maybe the medication they had a laxative. Um, you also have to rule out any medical conditions as well. So when we're talking about symptoms, it's symptoms new to them. So if they always have a loose stool, then a loose stool is not going to indicate infectious disease. They're normal for them. If it was watery and they're used to having a loose stool, then you may want to look at, okay, was there a diet change, any medication changes? And you would want to monitor that to see if they have any more symptoms. So it's important for those who care for the client to determine this, to decide if there's a true symptoms or not. You also have to be careful because your clients may not be able to report some of their symptoms. So example could be they're unable to verbalize that maybe they're nauseous or that they're having abdominal pain. So observations of them will be needed to determine if any of these symptoms are occurring, and that could happen through behavioral changes of the client. um, especially if there's pain. Also, frail clients with very small appetites may only have one episode of either vomiting or diarrhea due to their eating habits, and they may not exhibit other signs and symptoms. So these residents may be considered suspect, and infection control measures could be implemented. Um, Again, it's your staff and your facility knowing your clients and being able to make these judgments. If you're never sure, it's always better to err on the side of caution because you can always take down precautions very easily. What you can't do is put them up late and hope that spread never happened because spread will occur. So this is a flow chart that our infectious disease nurses have created and can be found on their website under some of their resources. Um, so it just kind of goes over a little enteric outbreak. So do you have two residents within a specific area, like having an epidemiological link with the following symptoms within 48 hours of each other. So again, that's the two vomiting, two diarrhea, or one of each. And then asking if there's a positive stool culture, if that has been able to be obtained. And then again, some phone numbers for you to reach them at, especially if you're suspecting an enteric outbreak, and some of the precautions that you should be implementing right away.
So now we're going to discuss steps within an enteric outbreak investigation. The Thunder Bay District Health Unit public health inspectors may respond to enteric outbreaks in order to try to rule out a common source causing the outbreak and prevent further spread. If many people become ill at the same time, this may indicate one main source, and a kitchen inspection and samples may be required to determine if there is contaminated food, contaminated water, or an ill person working in the kitchen. Public health inspectors may also be included if a specific agent is identified that is a parasite or bacteria that is commonly associated with food or water. Outbreaks can spread from person to person after the initial source. This results in a high secondary rate. In less likely situations, an investigation could also include the collection of information from residents, staff, and others who may have been exposed to contaminated food or water. Clinical samples from staff, including both symptomatic and non symptomatic staff, may be required. This could be directed to rule out healthy carriers of an infectious agent working within a kitchen. The only reason for the investigation is to ensure there are no ongoing risks to the clients within the facility. It is not to create blame. Most of the time, enteric outbreaks are due to person spread, which is normal and can be controlled through IPAC practices. Sometimes they are caused by lapses in food safety. Investigation is to find the problem, stop the problem, and educate moving forward so that it does not happen again. As a recap of IPAC outbreak control measures, we are going to pause here and review. So your facility is now an outbreak. What is next? It is important to remember the basic IPAC outbreak control measures. This includes additional precautions that are put in place immediately with anyone suspected to reduce the spread. Precautions can always be removed easily if no longer needed, but putting them on can contribute to more people becoming ill. Facility, unit, and resident door signage, which allows quick communication to staff, clients, families, and visitors via robocalls, emails, letters, or media. It's important to use whatever is needed to provide adequate and quick information for the facility. Increased hand hygiene. So it's important to recall that person to person spread is common with enteric outbreaks. Hand hygiene is the number one way to reduce transmission. Ensure that there are adequate supplies and signage to remind everyone to perform hand hygiene. As no one will perform hand hygiene 100% effectively, initiating enhanced environmental cleaning protocols reduces transmission. Additional environmental cleaning staff may be required to support requirements depending on the extent of the outbreak. And finally, engaging staff with ongoing education around IPAC to reduce spread among clients and staff. Staff may be more familiar with respiratory outbreaks rather than enteric. Ensure key messages are received and that they are received often. Outbreak control measures must be put in place to contain the outbreak. These measures are put in place to lessen the duration of the outbreak and reduce the spread to additional staff and residents. The document on the screen is what public health uses to guide decisions and decide which measures to initiate during outbreaks, not only in long-term care but in most congregate settings as well. Appendix B also gives an overview of outbreak management for hospitals and healthcare facilities. Most outbreaks are run the same way. During an outbreak, specific control measures are put in place with the goal of bringing the outbreak under control more quickly. Transmission-specific control measures or precautions are put in place as soon as individuals are experiencing symptoms. We shouldn't wait for an outbreak to be declared to implement measures. If you are in an outbreak and you are unsure if a client is experiencing symptoms or if this episode is normal for this client, control measures should still be in place until other reasons can be ruled out. Always err on the side of caution. Transmission or symptom specific control measures include droplet precautions, contact precautions, and routine hand hygiene. Droplet precautions may be in place if a predominant symptom is vomiting, as infectious droplets can be released. Contact precautions must be in place to reduce the spread of infectious fecal matter or droplets, as contact clients can directly or indirectly infect others or themselves again. Routine practice of hand hygiene will help eliminate any fecal oral route transmission. If the causative agent, so the bacteria or virus, is known for the enteric outbreak, this may determine if contact precautions are needed or droplet and contact. Personal care risk assessments are applicable, as these specific control measures create the minimal level of precautions, but based on your personal care risk assessment or PCRA, you may need to add additional decisions on restrictions for clients on affected units or areas will be made by the outbreak management team in consultation with the institution. If restrictions are lifted by the outbreak management team, but some clients continue to exhibit and experience symptoms of gastrointestinal illness, isolation precautions for ill clients should remain in effect to prevent further spread. The scope of restrictions on the affected unit or area are usually dependent on the affected areas and severity of the outbreak. Restrictions typically remain in place until the outbreak has been declared over by the public health unit. Timeframes for declaring the outbreak over may vary depending on the organism, but usually follow whichever comes first: 48 hours from symptom resolution in the last case, or no new cases after one infectious period plus one incubation period. For example, norovirus can be declared over after 5 days. Those assisting clients with feeding must follow proper hand hygiene procedures before and afterwards. If staff or volunteers are experiencing symptoms, they should be excluded from providing feeding assistance. Clients should be provided an opportunity to perform hand hygiene before and after each meal. A certified food handler must be on site to champion safe food handling practices. Catered food and food brought in by families should be approved by staff. Food for one client should not be shared with other clients without staff knowledge. Food should be labeled with date prepared and clients' names. Families should be directed on where to store this food. Symptomatic staff should self-isolate at home and not go into work. Staff should report being ill to their employer. Staff can return to work after 48 hours if symptom-free. This period can be modified if the causative agent is known. Staff who develop enteric symptoms at work are to perform hand hygiene and leave work as soon as possible. It's important to cohort staff to care for asymptomatic residents before caring for symptomatic residents when possible. Consider minimizing movement of staff, volunteers, or students between units or floors, especially if some units and floors are not.
During gastrointestinal illnesses and outbreaks, the following is recommended for disinfecting surfaces and equipment. Use a hard surface disinfectant with efficacy against the identified or suspected pathogen, for example, norovirus, and reasonable contact time. Don't use something that has a 30-minute contact time, which is also compatible with the surface to be disinfected and will not damage it. Consult with the health unit for more information on cleaning and disinfection practices. It is recommended that healthcare workers and staff handling soiled linens wear gloves and a gown due to the risk of contaminating their own clothing. Additional PPE may be recommended depending on the causative organism and risk of aerosolization from soiled linens. If the laundry machine has been used to clean soiled laundry, for example, with vomit or diarrhea, a bleach cycle of the laundry machine is recommended to be run without laundry before washing the next load. There are different criteria for declaring an outbreak over. For confirmed organisms, no new cases in clients or staff that meet the case definition for the time period established, which is based on communicability plus incubation period or based on 2 incubation periods. In general, for enteric illness, it would be no new cases in 5 days from symptom resolution of the last ill client. The actual declaration that an outbreak is over will be made in consultation with the outbreak management team. And now we move on to respiratory outbreaks and measures. Fall to early spring, usually October through April, is when we spend more time indoors and in closer quarters, which allows diseases that spread through droplets to spread more quickly. During this time period, we generally see a spike of respiratory illnesses in our region. Respiratory illness is also common in our congregate settings due to close living quarters and many shared common areas indoors. Residents also typically have a lowered immune system due to age or health complications. These are some of the common respiratory viruses that we see, which cause outbreaks within local facilities. Some will be familiar to you, and some may be items that you haven't seen before. A suspect respiratory infection outbreak is at least 2 cases in patients or residents. Staff cases may be part of an outbreak, but declaration of an outbreak should not be based on staff-only cases due to challenges ascertaining where staff have acquired an infection. We will review what is considered an acute respiratory infection and what is an epidemiological link.
An acute respiratory infection is defined as any new onset that could potentially be spread through the droplet route. So symptoms of a new or worsening cough or shortness of breath and fever, or two of the following or a combination of cough or fever and one of the following: runny nose or nasal congestion. It should be noted that elderly people and those who are immunocompromised may not have a fever response to respiratory infection. And that's why the second part of the definition was created, because then you could have a cough and a runny nose, or you could have cough and nasal congestion without that, and fever required as it is in the first part. So an epidemiological link can refer to, but is not limited to, a common unit, floor, common staff member, shared activities or dining area, a common visitor, or anywhere that there is evidence of transmission within the unit or site. A confirmed respiratory infection. That occurs when 2 clients who meet the acute respiratory infection definition on the previous page have onset of symptoms being within 48 hours of each other, having that epidemiological link, and have been test confirmed to have an acute respiratory illness. Or the same as I just said, but with 3 cases instead of 2, and no testing is available or all testing has been negative. So we just kind of use a diagram here for both to show that. So 2 with symptoms and positive, or 3 or more with no positive and they all have the epidemiological link as seen here on the same row. So the outbreak case definition varies with the outbreak under investigation. So always refer to the Infectious Disease Protocol 2023 or as current for guidance in developing the outbreak case definition as needed. Um, Outbreak case definitions are established to reflect the disease and circumstances of the outbreak under investigation. The outbreak case definition should be developed for each individual outbreak based on its characteristics, reviewed during the course of the outbreak, and modified if necessary. And this is to ensure that majority of the cases are captured by the definition. The case definitions should be created in consideration of the outbreak definitions, so the ones that we just went over. So consideration to that, but if you have, depending on the type of where the outbreak is. So for example, if you are on a dementia ward, they may not be able to express all the symptoms that they're having, or they may, if they're very fragile, they may have presentation a little bit differently. So that's why you're able to adjust the case definition for the outbreak if required. So let's take what we've learned from the first module. Remember that general outbreak control measures, and those are applied no matter what. So now your facility is being declared in respiratory outbreak. What's next? So we got to remember additional precautions. We want to remember about our signage. So that's for the facility, unit, and our clients. We got to remember the communication is very key, and the earlier it goes out, the better. The more clear and concise it is, the better as well. Got to get those PPE stations set up for your precautions. You want to look at that increased hand hygiene. So you're looking at quantity of supplies, locations of supplies, signage to indicate when it is required and to remind people. And you also, if auditing, if you're able to achieve that. Initiate enhanced environmental cleaning protocols and staffing. So do you have enough staff to initiate all the cleaning protocols required? And then that engage on that ongoing education around IPAC. So we are human, we're complacent, we all need those reminders. So we're talking about personal protective equipment, hand hygiene, physical distancing, all of that. So next we're going to talk about specific respiratory outbreak control measures.
So, some client control measures for ARIs or influenza. So, cases or ill residents should be encouraged to stay in their room and should be on droplet and contact precautions until 5 days after the onset of acute illness or until symptoms have resolved, whichever is shorter. For some pathogens, the period of communicability may be longer than 5 days. For example, if a client has RSV and is still symptomatic on day 5, they should isolate until symptom-free or until day 8. Consultation with the Public Health Unit infectious disease team will help determine what is required. Confirmed or probable COVID-19 case should self-isolate on additional precautions for at least 5 days from symptom onset, due to the longer period of communicability for COVID-19 versus other ARI pathogens. After the 5 days from symptom onset, if symptoms have been improving for 24 hours or 48 hours if gastrointestinal symptoms, and no fever is present, additional precautions can be discontinued. As part of outbreak control measures and to prevent risk of transmission from those with a longer period of communicability, clients are encouraged to wear a well-fitted mask if tolerated when receiving care and when outside of their room until day 10 from symptom onset. This may include avoid attending group dining and group activities that involve unexposed residents where masking cannot be maintained by the case. For COVID, 10 days, but if residents are not able to mask, they should remain on additional precautions for 10 days from symptom onset. Some client control measures include the use of antivirals. So antivirals are available for use in influenza and COVID cases or outbreaks. Antivirals do not cure the illness, but rather decrease the severity of symptoms, the length of the illness, and the viral load, which decrease the risk of spread to others within the facility.
For influenza, a plan is required to begin antivirals quickly, not only because treatment is most effective when started within 48 hours of symptom onset, but also because prophylaxis should begin as soon as possible to stop the progression of the outbreak. Advanced medical orders for influenza antiviral medication for clients should be obtained from medical staff at the beginning of each respiratory season, or a plan should be in place to obtain physicians' orders quickly in the event of an outbreak. Antivirals are covered for the outbreak if they are recommended by the Public Health Unit for influenza outbreak management. For COVID, long term care homes are encouraged to preemptively determine if a client meets eligibility, including reviewing medications for potential drug interactions and ordering a serum creatinine while the residents are well. It's important to connect with their contracted pharmacy about including Paxlovid in their emergency box, especially if a home is in a remote area. All long-term care contracted pharmacies have access to Paxlovid, and in emergency situations, homes may rely on their secondary pharmacy to access Paxlovid. If a patient is not eligible for Paxlovid, there are other therapeutic treatment options such as remdesivir. Residents and their caregivers are encouraged to proactively speak with their primary care provider. Healthcare providers in long-term care homes should work with their nurse-led outreach teams or regional contact to access remdesivir through local pathways. Retirement homes and other institutions are encouraged to provide information on COVID-19 therapeutics and encourage residents and clients to speak with their primary care provider to come up with a treatment plan in case they get sick. This guidance document was updated in February 2025 to include Appendix B that gives guidance for utilizing antivirals as a control measure for outbreaks. It includes COVID and influenza, discusses when a floor versus the entire facility should consider antivirals. It also talks about using antivirals as treatment or as prophylaxis. It also provides helpful, useful flowcharts. Overall, it's a great tool that should be utilized by any long-term care or retirement home. So here are some contact control measures for all respiratory outbreaks. Ideally, roommates, close contacts are placed in a separate room to isolate away from the case. When this is not possible, the use of physical barriers such as curtains or any cleanable barrier to create separation between the case and the roommate is recommended. For ongoing roommates, close contacts who remain in the same room should be placed on additional precautions for 5 days from the case's symptom onset, given their close and ongoing exposure. Following this period, the roommate close contact should wear a well-fitting mask if tolerated when receiving care and when outside of their room until day 10 from the case's symptom onset. If the roommate is removed from the case's room, they should be placed on additional precautions for 1 incubation period or 5 days if the pathogen is unknown. Following this period, the moved roommate should wear a well-fitting mask if tolerated when receiving care and when outside of their room until day 7 from the case's symptom onset. For non-roommates, the following risk reduction measures should be considered for non-roommate close contacts in the outbreak unit to reduce the risk of transmission to other residents, while balancing the residents' mental and social well-being. It's strongly encouraged that the resident should wear a well-fitting mask if tolerated when receiving care and when outside of their room for 7 days following their last exposure to the individual with the ARI. For all close contacts, this may include avoiding attending group dining and group activities that involved unexposed residents where masking cannot be maintained. Antiviral prophylaxis should be started as soon as influenza outbreak is declared and continued until the outbreak is over. It's important to consider a cautious approach to starting antiviral prophylaxis if the suspect ARI definition is met. For further details on the use of antiviral medication for prophylaxis, In an outbreak, please refer to PHO's antiviral medications for seasonal influenza document. So, some communal activity measures. So, for respiratory outbreaks, physical distancing should be in place in communal areas and dining areas where possible. For respiratory illnesses or outbreaks, measures such as physical distancing, masking, hand hygiene, and enhanced surveillance may be used for low risk group activities.
Healthcare workers or staff who develop respiratory symptoms at work are recommended to perform respiratory hygiene practices, which means wearing a mask, coughing into their sleeve or elbow, and maintaining hand hygiene, and leave work as soon as possible. For respiratory illness, staff should immediately leave and be directed to self isolate at their own home until symptoms have been improving for 24 hours and no fever is present. This is extended to 48 hours of symptom relief if they've been having gastrointestinal symptoms. For 10 days after the date of specimen collection or symptom onset, whichever is earlier, healthcare workers or staff should adhere to workplace measures for reducing risk of transmission, for example, masking for source control, and they should avoid caring for clients at highest risk of severe respiratory illness where possible. If healthcare workers or staff work in multiple settings or locations, it is recommended that they advise other settings or locations of the outbreak to determine if they should continue working in multiple places or be cohorted to a single location. All healthcare workers should conduct a point of care risk assessment before every client or resident interaction and task. For asymptomatic close contacts of illness, where feasible, additional workplace measures for individuals who are self monitoring should be in place. This means for 10 days from their last exposure, these measures may include active screening for symptoms ahead of each shift, ensuring a well fitting medical mask for the staff to reduce the risk of transmission. Individuals should not remove their mask when in the presence of other staff to reduce exposure to coworkers. For example, not eating meals or drinking in a shared space, such as a conference room or lunchroom, and they should be working in only one facility where possible. Staff who are unimmunized for any reason for influenza should be informed that in the event of an outbreak, they may be given the option of taking antiviral medication for the duration of the outbreak in order to continue their duties. Antivirals for staff carrying on activities in the institution or facility require a prescription. All staff should try to use their own physician or healthcare provider. However, in the event of an outbreak, and to facilitate providing eligible staff with timely antiviral medication, the facility may wish to discuss with the facility's ordering provider an opportunity for staff to access an antiviral prescription if this is applicable. If staff are unable or refuse to take antiviral medication for the duration of the outbreak, the health unit and institution should determine staffing needs for the setting on a case by case basis. It is reasonable to allow unvaccinated staff to work with clients or residents on an outbreak floor as soon as they start antiviral prophylaxis. Unless there is a contraindication, consenting staff should also immediately be offered immunization against influenza with the current seasonal influenza vaccine. The flu vaccine is your best defense against influenza and is recommended every year in the fall or winter, ideally before flu season starts. The flu vaccine protects you by helping prevent serious flu related complications, reducing your chances of getting the flu at the same time as other respiratory illnesses, which could make you very sick, protecting the healthcare system from becoming overwhelmed during respiratory illness season. The flu vaccine also helps protect people close to you because you're less likely to spread the flu to them if you're vaccinated. Pneumococcal immunization is available and encouraged for all adults that are over the age of 65. It is government funded and should be encouraged to any admissions or new hires as appropriate. It is available through an ordering healthcare provider and may also be available for those individuals who have prior health conditions. Keeping up to date with COVID-19 vaccines continues to be one of the most effective ways to protect yourself against serious illness, hospitalization, and death from COVID-19. Once a primary series is completed, every 6 months, dependent on health status and previous COVID infections, is the schedule to follow. Everyone is now eligible. Priority eligibility may occur when vaccine doses are low or with the release of a new vaccine. Check the Health Unit website for info. Current eligibility for publicly funded RSV vaccine is targeted at high-risk individuals and settings. The program includes individuals aged 60 years and older who are also either residents of long-term care homes, elder care lodges, or retirement homes, including similar settings, patients in hospital receiving alternate level of care, patients receiving hemodialysis or peritoneal dialysis, recipients of solid organ or stem cell transplants, individuals experiencing homelessness, and individuals who identify as First Nation, Inuit, or Métis. There are different criteria for declaring an outbreak over. For confirmed organisms, no new cases in clients or staff that meet the case definition for the time period established, which is based on communicability plus incubation period, or based on 2 incubation periods. For viral illness, this means no new cases in 8 days from symptom onset of the last ill client, or 3 days from the last shift worked by an ill staff member. The 8-day rule is based on the period of communicability, which would 5 days, and incubation period, 3 days, for influenza, and in general may apply to other respiratory viruses, with notable exceptions if the outbreak is known to be a virus with longer communicability or incubation, such as RSV or human metapneumovirus. The actual declaration that an outbreak is over will be made in consultation with the outbreak management team. Thank you for completing Module 2. If this has brought up any concerns or questions, please reach out to the IPAC Hub at ipachub@tbdhu.com, and we will be happy to provide information or resources as needed.